days of a 28-day course. The problem is once you start it, if you miss even one dose, we have to go back and start on a different medication. It's also highly toxic. The risks and the benefits are often not in favor of the patient. In order to administer it, we call the Center for Disease Control National Clinician Hotline. We provide them with all of the information about the patient and what the assault was. They will then tell us that they recommend it or don't recommend it. It's very, very expensive to do, and like I say, crime victims will pay for 3 days, and then you have to figure out a way to get them the remainder of the medications. So again, most clinicians are going to call the hotline, and they'll take that recommendation as to give it or not give it. And we actually give it very infrequently. Okay? We're also going to be looking at treatment for gonorrhea, chlamydia, and trichomonas, and bacterial vaginosis. Now, there may be, as soon as my nurse notices that there's any antibiotic allergies, they're not going to give any antibiotics because people are usually not, again, memory-wise, remembering really well. So we will do a panel of testing, and we will treat based on the results of those tests. Generally, most emergency rooms are going to go ahead and treat with something. It may be an alternative because of allergies, but they'll treat because they don't have the follow-up system that we have here in Snohomish County. But those are the standard things that you should expect to see. If you don't hear them talked about, it may be that she's already decided that that's not an option that is available for that patient. So again, talk to the nurse and say, I normally see that they give this, and I didn't hear you talk about it. Okay? Emergency contraception, there's a state law that says not only do you have to talk to them about it, but that you must provide the medication. You don't give them a prescription, you provide them with the medication. This includes all hospitals. This includes hospitals regardless of religious affiliation. And in fact, in regards to the Catholic hospital, the Ethical and Religious Directives for Catholic Health Care in 2001, the American College of Bishops said that a victim of sexual assault should be able to protect themselves from unwanted pregnancy. At this point, the FDA has approved it for 72 hours post-assault. There are agencies, medical agencies, that will provide it further out. And that can be facilitated by the emergency room or the nurse examiner if they are outside of the 72 hours that we can do in an emergency room, but within some of the other time frames for other agencies. Following all of the treatment, we're going to give them discharge and referrals. And again, know your system, know what's available to you. We're going to make sure that they have information regarding crime victims, and that's something that the advocates are within their standards of care. We're going to give them injury follow-up. If they have injuries, we're going to give them STD follow-up if we have any concerns. Certainly, you're going to provide information regarding crisis intervention. What should you do at 2 in the morning when all of a sudden you're having flashbacks, or you smelled something and all you can think about is what happened. Whatever your policies are regarding other emotional support, counseling options, support groups and such. And we should always have something in there that says, if you see this, return to the emergency room. That's just part of an emergency room discharge. What is the dire consequences, and you need to return if this occurs. Now, some specific strategies to look at. And some of these are repeats, some of these are going to be new ones. Know why you're having that nurse ask specific questions. Don't be afraid to say, why do you need to know how old she was when she started having sex? Okay? Understand that the person responsible is the person signing the report, the nurse, the emergency room physician. And if you provide well-meaning medical advice, which is a very slippery slope, and say, you know what, when I had swimmer's ear, my grandmother would put a couple drops of warm oil in my ear, okay? and then the child comes back with a perforated eardrum because of hot oil. Okay? Don't give out any medical, no matter how well-meaning, advice. And it's a slippery slope. You don't even realize you've done it until the nurse is sitting there staring at you with her mouth open. Okay? So be very cautious about that. Don't assume that because you don't hear the nurse say something that it wasn't considered. However, the patient may need to know that they considered antibiotics and not. So it may be something where you say, now, lots of times I see you give antibiotics, and the nurse should go, oh, yes, you know what? We're not going to give antibiotics because blah, 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 blah. Okay? So it certainly, like I say, we're thinking about it. We often don't communicate well, and certainly as well as we would like to. Remember that there's a huge variation in what you're going to see across the state in the provider, in the setting, what protocols they're currently following.